Maine's been losing hospitals for the last 100 years. The Jackman Clinic was a hospital. The clinic out in Castine was a hospital. It's not anymore. I mean, this is the reality, and we can't sit and pretend that how things are now is the ideal, and this is what we should end with.
That's a symptom of a decline.
Yes, exactly. There's pretty good data that for high utilizers, so people who are having more than 3 emergency department encounters, hospitalizations in a 3 to 6 month period, that initiating community paramedicine reduces their utilization from 50 to 70%. Estimated annual savings $12,000 to $15,000 net.
Yeah.
What is EMS? When people think about EMS and emergency care, what is it that we really care about? Well, in Maine, it's about 3.5% of our EMS calls. Life-saving interventions, time-sensitive life-saving interventions, things that need to be done in that first 10 minutes where someone is going to die or suffer a severe permanent disability.
3.5% are the golden hour, or the golden 6 minute. Hopefully it made it's the golden hour, because ain't nobody's getting anywhere in 6 minutes. And I can't believe I am live with the legendary Charlie Berger, the preeminent inventor. Today, there's venture capital dollars by the billions going into digital first care, delegating different chunks of what primary care is to different specialized teams. That started in the 70s, 80s with Charles Berger's practices. I built my whole career on building an electronic medical record. He was doing that 4 years, 5 years before I even started the company. So Charles, thanks for joining us today on Maine for Keeps.
My pleasure, Jonathan.
Now, I see in your movie star days, you're starting to surround yourself with adult supervision, which I think is very grown up of you. Jeff Brown and Jonathan Busko have become partners in crime. The three of you dominate the bagel place at least once a month in Bangor, saving Maine from its healthcare ails. Why don't we go with you, Jonathan? What are you working on these days with most of your time when you're not eating bagels with Berger?
Well, when I am not downtown, my main focus is really on figuring out where the holes are in healthcare. And there's plenty of them, but in Maine, with its rural nature and really vastly spread out, but not necessarily well-distributed healthcare resources, I see lots of opportunities for thinking about how to deliver healthcare unconventionally in ways that really serve communities. So I get to spend most of my time traveling around the state, working in our small rural and frontier communities and talking to people there and saying, what is it that you need, and trying to help them figure out how to get it.
And you're still practicing with the majority of your time when you're not putting together these policies.
Yes, I am. My medical practice is as an emergency physician, and then I also have a practice as an EMS physician in a physician response vehicle in Kennebec County, working with 911 services. And more recently, and this has just made international news, we've added to our focus overdose response and support for getting people into opiate use disorder treatment.
Good for you. And Jeff?
Yeah, so I am in the privileged position of being retired and able to focus on what I care most about, which is collaborating with Jonathan and Charlie to try to improve access and safety of healthcare across the state, particularly in the rural areas. My wife and I moved back here to Maine, our home state, in 2014. I have to tell you, Charlie Berger mentored my wife when she was a teenager. She, Larry Weed, and Charlie's colleagues at the Promise Clinic. And I was under Charlie's tutelage and didn't know it until I came back to Maine and finally met Charlie. Like you, Jonathan, I've always admired Charlie even before I knew him. So my focus is really on trying to improve access to primary care in the context of home and community. And my background is significantly focused on safety in complex, high hazard systems, and healthcare is certainly that.
All right, let's get into this theme that you're working on. I should tell you guys, the first business plan I wrote in the back of an ambulance. I was on from 6 at night to 6 in the morning in New Orleans, Louisiana. And as one experiences in such roles, a very large percentage of the patients were sufferers from chronic diseases that could have easily been stabilized right there in the ambulance. But instead, we would drive the patient to the emergency room where they would wait 7 hours to be stabilized, and then invariably end up spending the night for more thousands of dollars and then have to find their way back home. And I thought, wouldn't there be a great business here if I could show up for at least some of these and stabilize? And of course, I ended up finding Charles Berger's work on delegating authority in a primary care office to medical assistants. Instead of seeing the doctor, right, Charlie? And the doctor says, geez, you need a blood test. So then you send him off. You've just met with the doctor. It's too late. Now you get your blood results and you're going to get a letter about him instead of that's the time you should have been talking to the doctor. So Berger says to his staff, listen, if it's this, or this, just send them to the lab. I'm authorizing you to order for me. And then when I see them, I'll be sitting there with the lab results. And of course, this community medicine concept seems to be I ended up starting a different company, which did the same idea, delegating to certified nurse midwives instead of doctors for perfectly well pregnant patients. And the access, cost, quality measures were extraordinarily improved by that. So let's talk about this idea of community paramedicine in Maine. What does that mean? Jonathan, why don't you start? What does community paramedicine mean?
Absolutely. So about the same time you were writing business plans in the back of an ambulance, I was getting called into my medical director's office as a paramedic for doing just that. I was in medical school getting my master's in public health simultaneously and seeing those patients in front of me and saying, the protocols have enough flexibility in here. I could probably get away with just taking care of this as it is. And I didn't know as much as I thought I knew, but on the other hand, I also think I did good. And so that was back when we were first starting to call it expanded scope of service and practice EMS, with the idea being that a lot of the EMS care on emergency, and that there's also in EMS, at least in rural EMS, a lot of downtime. And when we think about how EMS is paid for, we think about sort of one cost, but it's not. There's two costs. There's the cost of readiness, and that is either paid for by volunteers giving up their own time, or a municipality, an organization pays people who are engaged to be waiting. And so they're simply sitting there. And then there's the cost
and
of
making a very fine lasagna most of the time.
Absolutely, absolutely. Hitting the gym in the station if they've got one. I remember those times. I'm not complaining about them, but it was time that my medical skills were not being used. And so this idea of what started out as expanded scope, and then the term community paramedicine, was coined by Kevin McGinnis in Maine, who was the previous Maine EMS director, and then ultimately mobile integrated health. The idea is that EMS is in every community. It is, for many rural communities, it's the touchstone of healthcare. If you have a medical problem, you either call 911 or you call your neighbor who you know is on the ambulance service and you say, hey, what do you think about this? That's how people traditionally accessed care in small communities that care for themselves. And so what community paramedicine does is it integrates EMS into the larger healthcare system by saying there is a non-emergency, non-transport care delivery that can happen using these trained and skilled providers. And so instead of transporting everybody, instead, the patients are identified who have what are called ambulatory sensitive conditions that can be treated through good access to ambulatory care. And the care teams, the physicians, PAs, NPs, nurse managers, work together to refer those patients to a community paramedicine service, to those individuals who go in and they assess and identify issues in maintaining health. A community paramedicine provider, and they're not all paramedics. In Maine, EMTs, advanced EMTs, and paramedics can all provide some level of community paramedicine. They're not home health in the strict sense. They're not community health workers in the strict sense. They're not social workers in the strict sense, but they're a combination of all of them. Their role really is to go into people's lives, go into their homes, like we do in all 911 calls. So it's what we do in EMS, but instead we go in with the view of what could make your health better. And it's assessing your pantry. Do you have enough food? Assessing your oil tank, assessing your trip hazards, assessing your smoke detectors, but also going through your bag of medications and inventorying them all and saying, you're on 3 of the same medicine prescribed by 3 different people. Are you taking all 3 of these? Because that's not how it's written. And it's helping fill pill boxes. But then for the people coming out of hospitals or who either don't qualify for home health or who have used all their home health benefits, or in Maine, live in places where a home health agency is responsible for that area but can't actually provide services, community paramedicine can offer some of that home health type of service. So medication infusions, wound management, more traditional home healthy type things. So I look at EMS as the spackle of the healthcare system. Because we're in every community, we can fill the cracks and gaps wherever they are, as long as we have the regulatory support, the educational support, and the big gap, the financial support to make those services viable in communities.
We'll get to the financial in a minute, but let's go back. You mentioned I heard a pile in there of sort of asset utilization, but also enhanced intelligence. Charlie, but before we get there, did you ever get in trouble for allowing non-doctors to order labs, basically make decisions to make you more efficient?
Yeah, I got into a lot of trouble. It was very controversial. I would sort of just preface this. We had all of the roles were very well defined in terms of skills. And so the principle I followed was that it didn't make any difference what their title was. If somebody was thorough, reliable, efficient, and thought well, and could demonstrate after a very well-defined training program that they could do something, they should be able to do it. It riled up the local medical community. I had to make appearances before the Maine nursing board. Yeah, and there were a few Eastern Maine Medical Center board meetings devoted to this topic.
Yeah, so that's kind of what I'm hearing coming on the horizon of this podcast right now, right, Jeff? Is that there's this model where a doctor a doctor is expensive, but they get really expensive if you pay them to not do anything for a really long time. And so if there's a gap, if there's an empty hospital or an empty doctor, the cost of every minute of that doctor's time that is used goes up and up and up. And pretty soon the people getting the care couldn't possibly afford it. So the idea, I love that name, spackle, Jonathan, is that you're saying, what can I put out there to make that doctor more useful? Jeff, where are we on the not getting in trouble? Do we all got to get dragged out in front of the tisk board the way Berger was to make this happen?
I think that, folks, anytime you engage in change, particularly changing the scope of practice you run up against regulatory requirements. You run up against professional culture. You run up against payment systems that constrain change. And I think it's inevitable that there will be conflict, but the goal is to provide more effective team-based care, consistent with what the National Academy came out with recommendations a few years ago, pay for primary care teams to engage with patients. Um, it's a change that has to happen. We shouldn't be afraid of a conflict. We should try to find common ground. The goal of helping people where they live. Some of the things Jonathan mentioned, like having eyes on the context of a person's life, to understand what may be contributing to their health issues.
Social determinants, as we like to say.
Yeah, absolutely. There was a case in my work in Washington County, Maine, where an individual was continuously returning to one of the critical access hospital emergency departments with respiratory difficulty on oxygen. It wasn't until, and she was coming in on her own, it wasn't until EMS went to her home and discovered that her basement was flooded. There was mold crawling up the walls, and there was remediation of those conditions. She was off oxygen. She wasn't continuously going to the emergency department. Helping people in the context of their lives is something we all really are trying to accomplish.
By the way, you reminded me of the first hot spotting study was in New Jersey. And they went and they took all the Medicaid patients in New Jersey. Remember this? And they found the single most expensive Medicaid. Who is the longest poll in all of Medicaid? And it was a guy in Atlantic City who was allergic, in Orange, New Jersey, who was allergic to his couch. And he would go back home from the emergency room, sit on the couch to relax, back to the emergency room. And somebody finally went to his house and says, "Hey, the guy can't breathe when he's on his couch." It reminds me of your woman in Washington County whose basement is killing her.
Yeah, but Jonathan, our other Jonathan here. I mean, and you can speak to it yourself, Jonathan. But there's been resistance from the Maine Nursing Association to the community paramedicine program.
Nobody wants work. If everybody's afraid, there's a culture of shortage, scarcity. I don't want you to get it because then I need it. And then if you let someone cheaper than me do something that would otherwise come to me, maybe I won't make as much money.
That's part of it. The other is the idea that we're so strapped that we shouldn't be building resources that replicate what other resources are doing. And I think that
certificate of need argument.
Yeah, but one of the things that Jeff said is the concept of team-based care. And if I'm thinking about how I'm going to deploy, if I'm a hospital care manager and I'm sending somebody home from their 11th admission for COPD exacerbation in the last 6 months, and I'm thinking about what resources they need, if they need traditional home health resources, then that's really who I should use because that's an area of specialization. But if I don't need those traditional home health resources, but I need someone who can really get into a patient's life in context and who can draw on all of the other identify the non-clinical determinants of health. I identify those other resources that are needed because they're in the community and of the community, then that's who I want to see that patient. And perhaps I want both of them to see the patient. And again, in Maine, there's a good number of places where I might say I want home health. And guess what doesn't exist where that patient lives? Home health. In which case, community paramedicine meets the criteria or principle of good enough is good enough. If they can do what needs to be done and they're who's available, then they're the ones who need to be doing the work. And I think that was one of the major barriers to the initial rollout of community paramedicine in 2012. And when it went off pilot status, there were again same barriers. We're going to home health agencies across the state are suddenly going to have these EMS agencies who aren't overseen by DHHS and who are going to be displacing them all. And that didn't happen. And now that we've finally, in the last 6 months, had a formal revision of the Maine Community Paramedicine Rule, Chapter 19, which really solidifies community paramedicine and what it means to be a community paramedicine provider, I still don't think we're going to see this proliferation of competition. And I know at least 2 home health and hospice agencies who are reaching out to community paramedicine services to contract with them, to augment their service, not to compete.
Let's just quickly make sure we understand the summary of what this is, and let's quickly summarize what we think it does that's good. So what it is there's already an ambulance there, and there's already people trained to be on it. They're mostly idle, so we're going to give them a little more training to be the eyes and hands of a doctor without bringing the patient to the doctor or the doctor to the patient. Is that the basic idea here?
Functionally, with one important caveat, at least in Maine, is that in Maine, we're not using community paramedicine to prevent transports in the acute call. And I'm going to say with a caveat of yet, because my goal is for us to also implement treatment in place.
So arms and hands of the doctor, in the safest of cases.
Yes,
Got
exactly.
it. Okay. And the argument is, I heard you say 3 things. The reason why we like it, one is it's less expensive per visit, that the ambulance is already paid for, the medic is already paid for. And if you can use that person and eliminate the giant weight, the block on the emergency room and the high cost, ready for a major incident emergency room, you're going to reduce the cost of that patient's experience. The second thing I heard was access. You might actually find out do things that person wouldn't have had without it. They might not have made the trip. And if they did, you wouldn't have ever known about the Jeff's example of the mold in the basement. So you're actually increasing medical access for people while reducing the medical cost. And then maybe there's something about, getting more people who aren't rich into the solution, that that going through the time to be an RN or an MD, God forbid, is, decades of work. Whereas an EMT is, a year of nights and weekends. The opportunity to have somewhere between those 2 things, where you can really fill in. So that's what we think. So we think this cures more people and makes the emergency room cost on the average person go down. Is that right?
That's right. And in some ways, I would actually flip the list of those 3 things. I would put the creation of essentially a career pathway in EMS, particularly in a rural community, as possibly the most important. Because in my heart of hearts, I mean, what is EMS? When people think about EMS and emergency care, what is it that we really care about? Well, in Maine, it's about 3.5% of our EMS calls. I looked at about 4 years of data. In 3.5% of EMS calls, life-saving interventions, time-sensitive life-saving interventions, things that need to be done in that first 10 minutes, or someone is going to die or suffer a severe permanent disability. That's what people think of EMS, and that when people first
3.5% are the golden hour, the golden 6 minute.
Yeah.
Hopefully it made it's the golden hour, because ain't nobody's getting anywhere in 6 minutes.
And that's the thing, is that you can't have particularly in a rural area. You look at a town of 500 people, you can't afford to have somebody sitting around in the station to be available to get to you in those 6 minutes if all they're doing is sitting around in the station being available. But if you have them doing community paramedicine and you have them doing other healthcare system integrated work, you've now created a career for someone or 2 or 3 people in your community that has value and also assures that fundamental emergency component that EMS is really built on.
I would say, furthermore, is it fair to say you're a better EMT if you're engaged in more treatment than the 3%, okay, 15 compressed 2, if you're engaged in the diagnosis pathology, ask for orders, deliver them, you're going to be better than if you're sitting idle for 97% of your time.
Yeah, and I think Charlie can probably speak to his perception of with his delegated practice, his MAs and others, how they were as clinicians compared to those who weren't given a level of responsibility they could handle above and beyond, which is what community paramedicine does.
Yeah, I think very definitely. And I think the other aspect is once the rules were well defined, and we operated off of a set of principles that we actually wrote up, and it was called the principles of practice, that sort of set the standards for accountability. And with their skills-based training, it allowed the staff to self-organize to meet patient problems without having to come and ask me for permission all the time.
This is a larger trend, right? There's books written about why nothing works, and all of these, the study they just completed, the Golden Gate Bridge safety net that they just built to stop jumpers, ended up costing more and taking longer than the bridge itself because of all the rigid compliance protocols that had to be followed. When if they just let people use their judgment, you'd have a vastly shorter decision cycle. And it sounds a little bit like what you're doing here. Jeff, let's break this out. Like, the first thing that's got to happen is the Overton window. We've got to be allowed to talk about it. It can't be like saying Voldemort, community-based medicine, pariah, how dare you, you're a scab, right? And then it's sort of make it legal after that, But then after legal, there's something else, right? Make it normal. Where are we on those three sort of barriers to acceptance right now? I mean, do people talk to you guys, or is it just the four of us and 9 viewers right now?
I'll just, I think Jonathan is probably the most up to date with regard to conversations regarding scope adjustment, for example. But in work that I've done in Maine with the FQHCs and in conducting some work in communities in Washington County, providers, primary care providers, and social workers, others, all identified the need to adjust scope of practice across roles so that you could have the flexibility, so that you could meet the needs in the context of community. And I think there's a willingness to have those conversations. I think that we can strive to keep people whole in terms of their identity with regard to their professional work, and as well as financially. Jonathan, I guess I would hand off to you to see what your concept of the current state is.
Right. So if you're unspeakable, illegal, unaccepted, golden, where are we?
So we've moved away from unspeakable. That's been good. And I think with this most recent passage of the new Chapter 19, we're into legal. We'll have to see how the rubber meets the road in terms of the Department of Health and Human Services, because while they have no oversight over Maine EMS, they do have oversight over just about everything else. And if they think that Maine EMS has stepped into other areas, that's the potential for complications. So spend enough time and enough hot seats to say we'll just see where that goes. So I actually think that we're in a place now where we're working on normalization, and that's been something exciting, and that right now, Community Care Partnership of Maine, which is the largest accountable care organization in the state, has a grant to support over the next 18 months 3 really important goals. And the first goal is around normalizing community paramedicine in the context of healthcare systems. So there are 2 hospitals and 2 federally qualified health centers participating in this grant, who basically all we're doing is teaching the clinicians there and the care managers, the care coordinators, this is what CP is. This is what it can do for you. Some of the hospitals, their care managers say, I've got a list of 200 patients already I want to refer. I know exactly who would benefit from this. Others are, and we just didn't know what this was. Others are saying, okay, we think we can identify patients and we can use data to do that. Health InfoNet and its predictive analytics. We can identify patients who we think will probably benefit. And then we're also supporting five EMS agencies to basically stand up community paramedicine from the ground up to support those normalized referral practices. And then we're also working with them to try to get to basically help them with the financial piece. We're using our CCPM is using its knowledge of working with payers. It covers about 400,000 patients in Maine, so almost a third of the population. They understand payer relations and shared savings and shared risk. And we're taking that expertise to help the EMS agencies to come up with sustainable business plans. So we're nowhere near normal right now. If an EMS agency said we're going to be a CP agency, and then we're going to go knock on doors at health clinics and hospitals and say refer patients, most of the time people would say to them, who are you? What do you do? How are you not home health? I think we've got this covered.
What I did not hear the word telemedicine or virtual care. Is that because there just isn't any in Maine? I would think that a virtual first provider would be a big user. Like I need hands on this person. I know them. I know what they need, but I don't want to make them go all the way to the emergency room, but I need hands on them. Has that shown up at all in any way, or why not?
So yes and no. And the yes is, of course, the pandemic. Everybody figured out, oh, we can use Zoom and talk to patients, but we didn't figure out how to make it so that it felt like a real visit. We ran a pilot project in Jackman, Maine, for 2.5 years, in which we used advanced practice paramedics who essentially were they were the hands, the eyes, and the treating capability for a group of physicians who were doing telehealth. So it was essentially a tele-urgent care. Patients would request the services. These advanced practice paramedics, what we called critical access integrated paramedics, would do an intake, decide whether it was an emergency that needed 911 or not. If not, they'd get a doc on board. They'd facilitate the telehealth visit. They were suturing. They were doing point of care testing. They were pulling foreign bodies out of people's ears, cutting out fish hooks. We ran into regulatory barriers, and those regulatory barriers. Yeah, no, I hear you. That I understand what the concerns were. I think that they don't reflect the reality of the way that we deliver, that we need to be able to deliver remote health services, because I do think that they are key to care. Now, one of the beautiful things about community paramedicine now being a legal, integrated, defined scope of practice.
Maybe you go back to that.
Yes, we built telehealth into community paramedicine. It's in the scope level. A CP can facilitate a telehealth visit at all levels now. And while suturing and taking out fish hooks aren't in the scope yet, there are a lot of other things, like someone who's having a asthma that's
A strep culture, preventable
Yep.
inhalers.
Exactly. So I can do a quick telehealth visit and have the community paramedicine provider collect a throat swab, or do a urine analysis, collect a urinalysis. We don't have them running the tests yet, but that's coming. That's clearly going to come. And we don't have them dispense. They can treat with certain medications. Massachusetts is a bit ahead of us on that, but very exciting. We got LD 239 through the legislature this year, and LD 239 lets retail pharmacies set up remote dispensing site pharmacies, which are staffed with non-pharmacists. The Board of Pharmacy has to write the rules. They should be out by next summer. And after that, you could be in a small town that's 60 miles from the nearest emergency department. And if you have a relationship with a doctor, They could schedule a CP visit for you if you have a complaint. You could be seen. A telehealth visit could be initiated, and then I could write a prescription that could be dispensed from that remote dispensing site pharmacy instead of you having to drive the 60 miles you would have. It doesn't save you any time if you were going to drive 60 miles to be seen in an emergency department if you still have to drive the 60 miles to go get the medication. So we're almost to the point where patients can get the full scope of services they need through facilitated telehealth and the originating site support. Not completely there, but it's an exciting.
Jonathan, one other, I think, important point of context is sort of the current collapse of our primary care system, particularly in rural areas, that I think is going to facilitate acceptance of these new systems and principles, because we just aren't going to be making primary care physicians at the rate that we need them, and nor should we, because I think we can.
And when we have one, they're not going to want to see 3 people a day. They're going to want to be in a busy place where they can make some money.
Right, and of course, the payment system is another problem. But I think we really have to start thinking about the whole system in the context of scarcity right now, which may be an opportunity.
Maybe a blessing in a creepy kind of way. Like the pandemic taught us to accept, virtual first care at a different level than we would have ever imagined.
Right.
Where are we on? It sounds like we're too early to see the real numbers on what this does to the total cost of care. I mean, we in Maine are really expensive. We're on the commercial side, we're $5,900 per employee per year, per person per year. That's $900 more than Massachusetts, which has, Mass General and other financial sucking sounds lurking around every corner. I feel certain that what you guys are working on makes a big dent in the total cost of care by moving the site of care further and further away from the high overhead, through the low overhead to the no overhead per patient. Do you have any data yet? Is there secondary data? Is there any proof points for the doubters? I mean, obviously, once the doubters see this podcast, they're all going to fall right over. But aside from
Clearly,
aside from that, is there any data that's out there on what this does?
Sure. So there's pretty good data that for high utilizers, so people who are having more than typically 3 emergency department encounters, hospitalizations in a 3 to 6 month period, that initiating community paramedicine reduces their utilization from 50 to 70%, with estimated annual savings $12,000 to $15,000 net. So gross being much bigger, and if you're not getting paid for anything, it really doesn't matter regardless. So that savings is a big deal. It's also, I mean, from a quality of life perspective, I have never met a COPD patient who wanted to be in an emergency department for an acute COPD exacerbation. They want to be at home. And when you talk about goals of care, goals of life, it's, I want to be with my kids. I want to be with my grandkids. I want to be able to fish. I want to be able to be at home. It's not, I want to spend as much time as I can hanging out here in the emergency department with all you nice people. And so if we can get cost savings and we can get that better quality of life, I mean, there's the financial and then the human benefit of providing that care.
I wonder whether this pressure on Medicaid that the whole country's going to experience coming up will lighten people's grip on resisting.
And one of the other aspects that we're looking at is part of team care, Jonathan, is how some of the new artificial intelligence support systems coming along can be team members, or as Jonathan has appropriately termed them, colleagues. And I think that's going to be very transformational.
Yeah, it used to be when you had a little man in your head, you needed to go to the hospital. Now you need a promotion.
Right. It's I would add to what Charlie just said in that artificial intelligence and the ability to engage in the context of home could make co-production of care a reality, much more so than it is now. If we are with people in the context of their life, as Jonathan put it. And I think with regard to your comment on Medicare, Jonathan, um, we need to get ahead of that. And uh, building upon the foundation of community paramedicine, what Jonathan and other EMS colleagues have already accomplished, to design a new primary care system that works for very rural people. May eventually, if we can make that work, may eventually help all of us, regardless of where we live, urban or rural.
I think that's right. I feel like this is another case of as goes Maine, so goes the nation. If we can get it working, use the fixed constraints of not being rich and not being urban to make ourselves do this and get it flowing, then everyone's going to look over and say, Jesus Christ, 50 to 70% reduction on the long pole in the tent, those acute cases. I mean, that changes everything. I don't even think the hospitals want those sort of ED clogging cases, even on their greediest day.
Now, particularly, they don't want them readmitted.
Right,
They don't
right.
want, they don't
These
want those
are all by
penalties. So.
definition readmitters, right?
Yes, absolutely.
But it is true. There's only so much money in the system, and our two largest hospital systems now are running significant deficits, and so we're dealing with a complex system, and not all agents in that system are going to be enthusiastic about what we're trying to do.
What are the three things that are next? What are the three next dominoes that we ought to knock down to get this to be normal, to get rural Maine care to be real time, to get the cost of these acute cases down 50%? Like, what are the next three dominoes that need to fall to get that to happen? We'll give you each a domino. Jeff, you go first. Jonathan second, and Charlotte's Berger, you close it out.
Yeah, the single domino. The complexity of this always has me thinking of multiples of dominoes, but we need to get people talking about piloting this work. This is not going to come out as a design that we know works right away. We have to develop iteratively a system that works for people in a specific context. We need to be context sensitive, rural, in a rural community where there are few other options, where it's going to be hard to say, no, we can't challenge the existing role boundaries, or we can't challenge the regulatory structure that inhibits innovation.
So it sounds like domino one is just more pilots running, more people tasting. If we want a rocket ship, we need more people using the skateboard. Is that right, Jeff?
Yeah, and I have had some opportunity to have conversations with multiple communities in this state, focusing on Washington County a few years back, where you can easily identify people who are ready to work with you to innovate and to try something new and to develop it with guardrails, so that you are trying to assure that people are cared for safely and effectively, and that you have the commitment or the support of the people who are needed to make it work. So I'll stop.
Jonathan, what's your domino to get down on the ground?
My domino is breaking. We've got to completely blow apart the silos of care responsibility.
And maybe the financial silo, right? Because you're doing a little bit of robbing Peter to pay Paul with this.
Well, yes, but so fundamentally, when we say, okay, gosh, we're spending 20% of our GDP on healthcare, we need to spend less. That means we need to spend less. Like that's a fundamental piece of making healthcare accessible and affordable. Is it we have to spend less money doing it, and less money means that you're doing less, and that acute care hospital. Nobody building anywhere else in the world building healthcare systems with any formal organization are building healthcare systems around very large hospitals,
fixed overhead edifices.
Right. It is very much distributed healthcare, and I think that as sad as it is that we're seeing communities lose hospitals, Maine's been losing hospitals for the last 100 years. The Jackman Clinic was a hospital. The clinic out in Castine was a hospital that did a lot of OB, and it's not anymore. I mean, this is the reality, and we can't sit and pretend that how things are now is the ideal, and this is what we should end
Right.
with.
That's
So
a symptom, of a decline. If we have reliable, instant on healthcare that's affordable, more people will be there. If there's more people will be there, all kinds of things will be there, not the least of which are hospitals.
absolutely. So if we can break down the roles and say every health is not something that happens in the context of healthcare systems. Health is happens in the context of humans' lives, and so no one person can or one role can be responsible for somebody's health. So we need coordination, the combination of someone who can clinically coordinate services and the use of AI colleagues to help organize and sense make the ridiculous amount of data that we generate, and then know who we have that forms the local most to the tertiary care most touch points, making sure that people are at those touch points getting those services when they need them. So we're not competing between specialties. We're saying this is the right specialty in the right context at the right time for the right patient, and knowing how to do that. And I think we're getting there. I think, and I agree with Jeff. I think that that curated, well used AI as an adjunct to every other level of human intervener and provider gives us that ability to basically say, this is the service that you need. How do we get this service to you in a way that works?
Okay, last domino, Charles Berger.
Major League Baseball was undergoing some scrutiny by the Congress, and Casey Stengel went before the committee that was investigating this, and he went on for about an hour. And he was followed by Mickey Mantle, and Mickey Mantle said, I agree with what Casey said. So I agree with what these guys said, but I think also we're really looking this very much in the system sense. I mean, the old saying, every system is perfectly designed to produce the results it gets. So we have to expand out beyond paramedicine. And I think at least one of the advantages I think that Community Care Partnership of Maine has had is they've already established risk contracts with payers. And so we have to also figure out, how do we mitigate the financial risk to some of these other institutions? Because we don't want our hospitals going away. So how do we pull them into the mix and help them be successful too?
Although I would say, Charlie, we may want some hospitals to go away, but we need to do it in an intelligent way. If there are duplicative services that simply have too much overhead and will never get to a place where we can say this is a good thing. But right now, hospitals are closing not because that they're the right hospitals to close, but simply because of the winds of fortune of their reimbursement or changes in population, or decisions made 40 years ago about what infrastructure to put in place that's resulted in costs that can't be controlled. So I think we need to be thinking not in a CON kind of way, but just from a what is the benefit? What benefits does each element of the healthcare system add? And if it's not adding a benefit, then we may need to let it go.
Amen.
You call yourselves the Sisyphean Medical Society. I call you the Mavens of Bagel Central on Central Street in Bangor. You are getting the rock up the hill. There is green shoot everywhere in what you're doing. If you succeed, access to care will go up and cost of care in Maine will go down. Jonathan Busko, Jeff Brown, and Charles Berger, thank you very much for this inspiring and enlightening episode of Maine for Keeps.
Thank you.
Thank you,
Thank
Jonathan.
you, Jonathan. Thanks.
Thanks for tuning in to Maine for Keeps. I hope you enjoyed it. Be sure to follow us on social media, click and share with your friends, or get on to mainforkeeps.com. If you have ideas for new content or podcast guests, or if you'd like to give us some money to support the effort, be sure to click and send. We're at team@mainforkeeps.com, and I'm at jb@mainforkeeps.com. Thanks. See you soon.